She's a 4-year-old present to casualty with a limp. So here we will deal with a child, a limping child who is 4 years old. Okay. When we have discussed recalls, I have told you limping child, always concentrate what is the age. Basically, in your pediatric guidelines, they have given a table of the limping child where like what is the age of the child and what you will make your top differential diagnosis in the patients. Okay, so here they are talking about a 4-year child who coming to me with a limp. All right, this he's thought to have an irritable hip. So see, always see, like a 4-year child, I thought this is a case of irritable limb. Okay, after a normal hip x-ray, he is discharged. So after discussing this, we will read what is irritable hip. Like why they have labeled this. They got a normal hip x-ray with a limping child. The child may be having normal CBC. The child may be having slightly raised or normal ESR and CRP. So what they did, they said this is a case of irritable transient tenosynovitis, so they discharge the patient. He continues, but what is going to happen? He is going to have intermittent hip and back pain, and it is seen by the GP who follows him up for anemia. In one case of your four clinical cases, they have said, and yes, that is the rule. In case of children, back pain should not always be ignored. Back pain is always having some diagnosis, some pathology in the case of pediatric population. Okay. So first this child came to me with the irritable hip. I discharged the patient, but this poor child is having intermittent hip pain and back pain. That is dangerous to me. And GP follows him for the anemia. So findings are what? Back pain, that is very significant. Intermittent hip pain, that is significant. And anemia, that is significant. The anemia fails to respond to the 4 week of hematinics, and he is referred to the nearest hospital. This is also a like key point in many diseases. The patient is anemic, but he's not responding to the hematinics. He has a right-sided limp on admission and complains of the pain in the right leg. Okay. Now his HB 7.5, that is very much decreased. There are no other clinical findings. What investigation would you do next? Select 4 answers. Okay. Repeat hip x-ray. Okay, what you have taken here, what is our problem in this case? Is this a case of B12 and folate deficiency? Okay, we will not jump to the neuroblastoma. Yes, you are Dr. Genia, very right. But let us see that maybe, let us see, let us discuss. Is this a case of B12 and folate deficiency? The child is not moving properly. Maybe he is having some due to vitamin B12 deficiency. There is posterior column of the spinal cord that is being affected, and that is why he is having back pain and others. Is this a case of B12 folate deficiency? Okay, Dr. Razia, this is B12 and folate deficiency. Okay. This is not a B12 and folate deficiency. I picked up like just to make this the answer of this clear, like anemia fails to respond to 4 weeks of hematinics. Hematinics never always mean like you are just giving iron. That may be your folic acid. That may be your multivitamins too. Okay, so this is not this case. Why? Because they have clearly told me they have given hematinics. That may be iron, that may be vitamin B12, that may be folic acid, and the patient is not responding to. So it has been excluded, right? Is this a case of, okay, will you go for the repeat hip x-ray? Will you go for repetition of the X-ray? No. Why no? And if yes, why yes? Okay, will you go for MRI of the hip joint? So I guess before moving towards the infection, okay, let me give this scenario to you again. No, I'm just, Dr. Genia, I'm just discussing this part one. This child, I'm giving you this scenario again. A child is coming to me with a joint involvement with a limb. Okay, I discharge the patient. I send this patient to home, but after few weeks, this patient is coming to me. See here, this child came to me. He was having irritable. This was my suspicion. Like this child is having irritable hip. Maybe he is having some problem. After few weeks, he is coming to me with the hip involvement, with the limb. Okay, with pallor. Okay, one feature, two feature, and this is he's also anemic, right? What is the other feature? The child is not well, not well. Okay, so what is my suspicion here? The child coming to me, I took this is a normal hip X-ray, so I discharged the patient, but the child is not feeling well. He continues to have intermittent hip pain, back pain. He is pale. Is not responding to the iron treatment, folic acid treatment, vitamin B12 treatment. Okay, so what is my suspicion here? My suspicion here should be malignancy. That may be a case of malignancy. This malignancy, yeah, my suspicion here should be malignancy. That malignancy is maybe that it may be of the primary bone tumor, that may be metastatic metastasis to the bone, which has causes limping of the pain. Septic arthritis, this is not a case of septic arthritis. What is the typical presentation of the septic arthritis? That is your arthritis. Which joint is involved? That joint is swollen. That joint is having pain. Okay. Here they say there is no clinical finding. Joint is not involved. Okay, so see here, this patient came to me with a normal hip X-ray, but the patient is going to have the features of the joint involvement again and again. So what should I do? I should repeat the hip X-ray. Okay, I should repeat the hip X-ray. Maybe all features they are not present at the time of the initial presentation. Now the features on the hip X-ray may be present. I should not go for the MRI of the spine, for the bone scan, for the skeletal survey first. This child came to me suppose 4 weeks back and his X-ray was normal, but the patient is continues to have the joint involvement, the pain in the joint, pain in the bones. So I should go for repetition of the hip X-ray to compare it with the previous one. Okay. Next, my suspicion is malignancy. That may be of the primary bone tumor. This repeat X-ray will also make me clear like there is bone malignancy. Okay. And for the primary site of the malignancy, I should go for the CBC with blood film. Okay. With ESR and with the chest X-ray. Chest X-ray to look for this neuroblastoma. You may look it for some lymphomas and others. These may be the most common site for the malignancy which are having metastasis towards your bone, especially the neuroblastoma. Okay. Is that clear? This is clear or not? So here I should go for the repetition of the hip X-ray and I should look for the primary malignancy. This MRI of the spine, this the bone scan skeletal survey, I will go after my confirmation of the X-ray findings if they are giving me a clue towards any diagnosis. Okay, here they have specifically mentioned left knee X-ray. No, the child came to me with the limp and I was suspecting is it as a case of irritable hip, right? So I will repeat the hip X-ray first. Okay. Next, they say on reviewing the first X-ray, like it means they couldn't pick up when the child came first to me. There was a small lytic lesion on the femoral head. So this is the femoral head where the child is having some small lytic lesion. What differential would you like initially consider? Select three most appropriate answers. Is this a case of hemophagocytic histiocytosis, osteomyelitis, histiocytosis, avascular necrosis, neuroblastoma, this one, and this one? First of all, give me three most appropriate answer. Then I will tell you why on the other options are not. What are the differential diagnoses of the osteolytic lesions? What are the differential of the lytic lesions on the long bones? Dr. Vajiha? Mm, avascular necrosis? No. McCune Bright? No. Osteoblastoma? Osteoblastoma, have they given among the option of the osteoblastoma? Dr. Sadaf, have they given among the option of osteoblastoma? No, dear. Look what in the options they have given. Have they given Ewing sarcoma in the options? You are right, but please look what are the options. Osteomyelitis. Yes, number one is osteomyelitis. Dr. Sadaf, they have not talked about the Ewing sarcoma. See what is in the HLH, hemophagocytic lymphohistiocytosis? No. Neuroblastoma? Neuroblastoma, yes. All right. The third option, histiocytosis. So among the three options, see here, this is osteomyelitis, this is histiocytosis, and this is neuroblastoma. Okay, please do remember these are the three options. And number 1 point, Dr. Sadaf, please always see what is given in the option. Try to concentrate on the questions given, right? Sometimes they give you like they will give you in the stem, in the scenario they will give you the ABGs, okay, and in the options for the answer they will like they give you ABGs, and in the question they will ask you what investigation you would like to do. One option may be CBC, second option may be ABGs, third option may be LFTs. So if you choose ABGs, that would be wrong. Why? They have done the ABGs. So try to concentrate on the question and what they are asking to you. Okay. In the option Ewing sarcoma is not there, so you will not say this one. Okay. So remember osteolytic lesion, that is your osteomyelitis, histiocytosis, and neuroblastoma. Okay, one of you said the avascular necrosis. How avascular necrosis is going to present? Is this with the osteolytic lesions or necrotic lesions? Avascular necrosis, like if we suppose it is the head of the femur, there will be distortion or destruction of the head of the femur. There will not be osteolytic lesions. I will show you how they are going to present. See here, this is the X-ray that is with your osteolytic lesion. Okay. Yeah, this is the X-ray with your osteolytic lesion. The first question is about the avascular necrosis. I will show you later on. Okay, this is osteolytic lesion. Now see, if we see the spine, these are the osteolytic lesions. This is osteolytic lesion. This is your osteolytic lesion. Okay, clear? Next. Okay. Basically, I want to. Okay, this. What is this X-ray? Okay, who will tell me what is your diagnosis on these X-rays? I basically want to tell you why other options are not chosen. Like if we talk about multiple slides, mm, this is an X-ray for the Albright hereditary osteodystrophy. Okay, how this is going to present? This is your pseudo hypoparathyroidism. This is the X-ray for the pseudo hypoparathyroidism. Here you have the short fourth metacarpal, number one, and this is the lesion which is your pseudo hypoparathyroidism, that is your calcified lines. Okay, this is not the osteolytic lesions. So in case of pseudo hypoparathyroidism, you do not have osteolytic lesions, rather you have this osteoclastic hyperdense areas which you see in the bone x-rays, and you have short fourth metacarpal bone seen on the x-ray of the hands. Okay, next, basically the other answers for like your McCune-Albright. What do you have in McCune-Albright? What is the X-ray of the McCune-Albright syndrome? Basically, they are given in the different questions, so I have not gathered them here. But you have in the polyostotic fibrous dysplasia. So what will be polyostotic fibrous dysplasia? That will be just like your pop bones. This is the bone, and this is polyostotic fibrous dysplasia. I have an X-ray for that given in another question. Do you have osteolytic lesions in slipped upper femoral epiphysis? No. There will be displacement of the epiphysis of the femur from the acetabulum. Okay. So, neuroblastoma, osteolytic lesion. Now the point, one of you said this is a case of hemophagocytic lymphohistiocytosis, and no, and I said no, this is histiocytosis. What is the difference between the two? I will tell you. See here, we will read this explanation. This is basically the histiocytes. These are the cells of your immune system. Okay. Histiocytosis means these cells, they are not under control and they are overproduced. Okay. Now what is going to happen? These are filled with the waste and the debris. These are the foamy histiocytosis. When there is uncontrolled production of these histiocytes, it is going to produce histiocytosis. There is always a triad for making a diagnosis of the histiocytosis. What is that? You have diabetes insipidus, you may have exophthalmos, and you have lytic bone lesion. So it means lytic bone lesion is essential to make a diagnosis of the histiocytosis. Okay, this is a diagnostic criteria for the lytic bone lesions. There are multiple types of the histiocytosis. Histiocytosis X syndrome or like Lettershy syndrome, and multiple types. Okay, need not to know for this exam, but yes, lytic lesions, that is essential to make a diagnosis of the histiocytosis. Okay, this is the diagnostic criteria for the hemophagocytic lymphohistiocytosis. It means here we have histiocytosis, but other cells like lymphocytes, like macrophages, like others, They may also have uncontrolled upregulation. So we have these criteria which must be present to make a diagnosis of the HLH. Okay, so what is that? They say there must be present fever. Have they given inner scenario fever? Yes, that was present. Cytopenias at a minimum of 2 lineage, splenomegaly, hypertriglyceridemia, hypofibrinogenemia, biopsy proven hemophagocytosis, right? They say in 2004 they added three more criteria. In 1994 they said there are five criteria and 5 by 5, just like your 33 by 33, must be present to make a diagnosis of HLH. But in 2004 they added three more things and said you may take 5 by 8 to make a diagnosis of HLH. What are the three others? Ferritin greater than 500. Here they said hypertriglyceridemia and hypofibrinogenemia, but later on they also added the ferritin level as a diagnostic criteria, low or absent natural killer cell activity, and elevated this level greater than to this one. So need not know learn about, just to tell you why this is not a case of hemophagocytic lymphohistiocytosis. We need one, two, three, four, five things to label any disease as a case of HLH, but we need three things like diabetes insipidus, osteolytic lesions, and this what was the third one, exophthalmos, to make a diagnosis of the histiocytosis. So if we talk about the differential diagnosis of the lytic lesion of the long bones, we will definitely try to search for the histiocytosis, not the